ready to go. I'm giving you a series of patients that had very unusual situations following anterior segment surgery. It happens, and I'll show you to whom it could happen. We have no financial interest in this, but as you can see, it's quite an emotional one. Let's go through some cases. The first one was a 68-year-old female. She had various illnesses. You can see she had cataract surgery in the other eye, and after that she had punctate epithelial erosions, or P's. Both eyes worse than a pseudophakic eye. Mascara, she was treated with this and that. It was worse in the pseudophakic eye, clear in the phakic eye, and so afterwards it got better in the pseudophakic eye, and vision went bad in the cataract eye, so I went ahead and did surgery. And you can see, despite the steroids, Acuval, the non-steroidal, she was placed on that, and she had a clear epithelium right away. But 3 weeks later, she came in with this, a stromal melt. A stromal melt. We cultured it, everything was negative. We went through sophisticated labs, anti-nuclear antibodies and anti-nuclear cytoplasmic antibodies. Everything was negative. She needed a penetrating keratoplasty, and sure enough, even that developed the P's. And vision at the end, 2200. Here's another case. 76-year-old male. Dry eyes, corneal sensation intact. Again, he had the punctate epithelial erosions, Sjögren's syndrome suspect. We treated him with all types of supplements, went ahead, did the cataract surgery, including placement of plugs, Acular. Notice we used that. And this patient, 1 week appointment, believe me, we had snow in the desert. No snow plows, he could not make it to the office. But he telephoned me. Vision was more blurred, but no redness or pain. He came in finally when they shoveled the snow away. Corneal melt, dysmetaseal, microperforation. I had to put Dermabond on, glued a contact lens, and ultimately had a penetrating keratoplasty as case number 3. Sjögren's syndrome, refractive lens exchange for +9 diopters, corneal perforation. That had to be glued with a soft contact lens, and silicone plugs placed, lateral tarsorrhaphy. And the fourth case, this patient had 3-week corneal melt after cataract surgery, again on Acular, and again penetrating keratoplasty. And here he is after the penetrating keratoplasty. So let's take a look at these patients. 3 of them had superficial punctate keratitis, poor tear flow in one case from Sjögren's syndrome, and cases 2, 3, and 4 the same. Absent corneal sensation in 2 of the cases, Acular non-steroidal used in 3 cases, and a non-steroidal of a different brand in the other case. Some of them had Sjögren's syndrome, poor tear flows, but notice the melts did not occur at the place of cataract incision. It occurred more centrally. They all underwent penetrating keratoplasty. We plugged them, put them on doxycycline to improve the tear flow, autologous serum, Lodimax. Here's case 2, 9 months later, and after the lateral tarsorrhaphy cleared. Here's same patient, the unoperated eye, heavy stippling, and doxycycline, and this one also autologous serum. So here's the vision outcomes. I think we did pretty good. All right, let's go into pathophysiology if there's time, because these ocular surface diseases, we have a very delicate biochemical environment that can be disrupted with anterior segment surgery. You can see the different types of disease states, and neurotrophic keratitis is very important. Again, I spoke earlier about matrix metalloproteinases. There are enzymes that could dissolve the collagen, and it increases in ocular surface disease as more polynuclear cells come into the area, and they have the MMPs and and the inhibitors, and that leads to stromal melt. So it keeps getting worse and worse and worse, more recycling. Okay. Both the extracellular matrix increases, and you have to have a nice, delicate balance. We talk about substance P and acetylcholine the same way. So in neurotrophic keratitis, here's the classification. I won't go into it, but stage 3, stromal melt and perforation. The NSAIDs used in conjunction with cataract surgery to reduce cystoid macular edema, but still it's controversial. So what do? Don't use it in high-risk cases that have the dry eyes, Sjögren's syndrome, poor corneal sensation, and do give it aggressive lubrication in any of these patients with plugging, tear supplements, tosarafy if necessary. Yes, you could use a different type of steroid solution to reduce it in cyclosporin A. Here are the references. Not that I expect any of you to read them, but thank you for listening.
Yes. Very, very well. Beautiful paper, Dr. Schultz.
Thank you.
Tell me, all your 4 patients who went in for corneal grafting, did you do the corneal grafting or did you have to refer it out? You did it yourself?
Yes.
Perfect. And when you did the corneal grafting, did you?
With Dr. Navarez, we worked together.
Okay.
Navarez is corneal surgeon at Loma Linda, and of course I'm there too. So we work in conjunction.
Okay. Was there any difference in the post-operative care that you gave and they gave? Was there any difference here?
We worked in conjunction. We worked in conjunction with each other on these difficult cases.
So your post-operative care would take care of an antibiotic, steroid, what else?
Yeah. And we're very aware of this now in preoperative patients. They're tear-filled, they have keratitis, Sjögren's syndrome, plug them, and aggressive with lubrication. And we're not too aggressive in going after the cataracts unless they really need it. And then they get special care. In other words, you have to tone your aggressiveness back.
Wonderful, wonderful.